Hello, this is Jess. This is chapter 3 of the pre-op post-op slideshow that I'm recording. And we're going to talk just for the littlest bit about intra-op or peri-operative care. So that's in the procedural area, intra-op, peri-op. Share my screen so you can see what's going on. There you go. So this link is live and it works, and it is a really fun surgical timeout. So what should be included in a surgical timeout? When we are when we are functioning as the nurse in the operating room or in the procedural area, one of our biggest responsibilities as that patient advocate is to call the timeout. So the patient can be under sedation for this, that's okay, but the patient needs to be verified against the paperwork. And everybody in the room stops what they're doing. This particular picture that you see here, where everybody's kind of like doing their own whatevers, this is a big no. This is not when we call timeout. We call timeout before anything starts. And timeout is the chance for everyone to be on the same page. We need to make sure we have there's all of those rights of medication. All of those medication rights are very similar to the timeout rights, because medication is an intervention that we do on behalf of the health of our clients. So is surgery, or procedures, or whatever it is that you are all scrubbed up in a sterile environment for. So those timeouts are the nurse's responsibility, and everybody needs to pay attention. If there is somebody who is not paying attention, you get to put on your nursey bossy pants and you need to make sure that people are paying attention. This is the timeout. I have patient, Joe patient. Yes, we have Joe patient as verified on the wristband. Joe patient is getting a okay, that is the nurse's job. And it's one of our biggest advocacy points, especially in the procedural area. All right, so now surgery's done. There's a lot of things that as the RN, we have different jobs in the surgical area. We have some different things going on in the surgical area. And those are specific, and you'll learn a little bit more about those if you decide to go into OR nursing. For the purposes of today's lecture, I'm going to leave it at the timeout. So surgery is done and the patient's going to go to PACU. Yay! So there are different post-op nursing assessments that are done, and the post-operative nursing is talked about in chapter 19 in your Lewis, as well as care of a patient on admission to the clinical unit. Because sometimes we have clients that go into post-op with the intention that they are in day surgery and they're going to be going home. Sometimes people come into PACU, the post-anesthesia care unit. That's what PACU is. So sometimes people are going into PACU so that they can go home that same day. Sometimes people are going into PACU so that they can go to the floor. Sometimes people think it's either a scheduled discharge or a scheduled transfer to intensive care. Sometimes it's not. So sometimes people will go to the intensive care, they'll go to the progressive care unit, they can go to the med surg unit, depending upon what they have going on in that particular surgery or procedure or whatever it is that they were in that suite to have happen. There are different post-op complications that can happen. So we'll talk about this a little bit in class too, but I want you to understand that there can be some really abnormal vital signs, and there are degrees to the abnormal vital signs that happen in PACU. So there's okay abnormal, and then there's this is really not okay abnormal. You can have bleeding, you can have low blood oxygen, you can have delirium, you can have pain, you can have altered temperature. Later on in the life, in their recovery period, you can also have ileus. That's a vocabulary word. I'm going to have you look that up. ileus. They can have infection. Think back to term 1. You probably talked about ileus in term 1. They can have infections, and they can have infections in their surgical site, in their wound. They can get a bladder infection from their urinary tract, from the Foley catheter. They can also get respiratory infections, either from, let's think about all the different ways they can have respiratory infections. I'm going to stop myself there because I was going to go into this whole thing. And then they can have atelectasis. Atelectasis, vocabulary word. I'm going to have you look that one up too. That one you probably didn't talk about in term 1, but it's an important one to talk about because it will actually end up exploring atelectasis at a little bit greater detail later on in the term. But if we can get familiar with vocabulary words now, all the better. And then constipation is also a post-operative complication that can happen quite regularly if we're not careful. So there are times where those surgeries are written in medical. And it's really sometimes confusing to understand what the medical thing is. So the longest thing that I've had to write on a surgical consent, because sometimes I would help out the doctor and I would just write the procedure on the consent, wouldn't consent the patient, just transcribe the procedure, was a transesophageal duodenoscopy. And I think I missed some stuff in there. So that's a lot of words. Even if I didn't know what the surgery was 100%, like what it meant, the transesophageal duodenoscopy, I still needed to know what to do after surgery. So what is our priority after surgery? What are the big things that we are always worried about with our clients? Think. I'm going to give you a pregnant pause to think about that. Okay, so if after that you came up with, we need to make sure that they're breathing and their airway is clear. Yes. So there's a couple different things that we can use to make sure that their airway and breathing is working well. There is incentive spirometry, and there is expirometry as well. So the incentive spirometer is the thing that we have in the picture here. And a lot of people will mix it up and they will try and blow on it to make the disc move up and down. I tell them it's the vacuum game, or you suck on it like a straw. Usually that works a little bit better in terms of patient education about how to use this particular, very simple piece of machinery to try and help expand their lungs. Because if they're treating it like the vacuum game, or if they're sucking on it like a straw, what happens is it helps to those alveoli down in the bottom of the lungs. If for whatever reason you couldn't hear me, like do that, let me do it again. Pop open those bottom alveoli in the lungs. So if we can get big, deep inspirations like you can get by sucking in a straw, by playing, vacuum with that incentive spirometer, that will help keep the lungs open and prevent atelectasis. And then this expirometer helps to push out air as well. So both of these particular pieces of machinery help to enhance breathing and give the client a visual about how well their lungs are working. In post-operative land, we may be using some different medications. Let's think about these. Let's go back to pharmacology again. And let's talk about post-operative medications. So what I would like you to do with this particular slide is I'm going to assign you a little homework again. I do require every once in a while that you interact with the videos, even though I can't gauge whether you're interacting with them or not. And I would like you to write down, like in your notes, when you would use these particular medications. When are you going to be using an albuterol metered dose inhaler? That's what an MDI is. Quick refresher. When are you using Zofran? When are you using Reglan? When are you using Tylenol? When are you using fentanyl IV versus a patch, perhaps versus Tylenol? When are you using patient-controlled analgesia, that PCA, that like on-demand analgesia? What sort of situations is this called for? What sort of situations is this not called for? One of our advocacy jobs is, do we have the right medication for the right patient for the right purpose, right? Part of our rights of medication administration is we need to make sure that we have the right purpose. So if we have somebody with 10 out of 10 pain and all they have is Tylenol, is that right? If we have somebody with 2 out of 10 pain and all they have is fentanyl, is that right? So take a look at these different, I kind of gave that away, didn't I? Oh, well. Take a look at these 6 different medications. Why do we use them? So there are some phases of PACU. And so PACU phase 1 is all about ABCs, airway, breathing, circulation. How are you breathing? How's your heart? Are you perfusing? So we're going to be looking at ECG rhythm strips. We're going to be looking at telemetry. We're going to be looking at ventilators. A lot of these people in PACU phase 1 are still on the ventilator. They still have a breathing tube. They may or may not have an arterial line, depending upon the procedure that they had. And the goal is to get them transferred to inpatient care. If they're transferring on the ventilator, they're going to the intensive care unit. If we are extubating them in PACU, then they go on to phase 2. So phase 2 is where we're extubating. We're removing some different, we may be removing some different lines, maybe that arterial line, and we are preparing to get them transferred to somewhere else. So your med-surg unit, your progressive care unit. Like I said, if you're going to be staying, if the client is going to be staying on the ventilator, they're going to ICU. You may have clients that you transfer to ICU that aren't on the ventilator, but if they're on the vent, they're going to the ICU. And then PACU phase 2 takes a little bit longer. We're going to be the ones, and as the PACU nurses, taking them off the breathing tube, and we're going to be the ones who are making sure that everything's cool to discharge somewhere else. There is a surgery discharge criteria listed on page 343 in your text. Basically, and then underneath this blue line is kind of ambulatory. So this is your same-day surgery checklist in some ways. So PACU for surgery, or PACU phase 1 is still the same. We're still going to make sure that they can be off the vent, that they're on the vent, that their ABGs are okay, that they're moving the air around the way they should. We're going to make sure their heart's okay. Once they can get discharged from phase 1, then phase 2 happens. Phase 2 in ambulatory care looks a lot like this. So no IV narcotics for 30 minutes. They've peed, they can walk. They have a responsible adult to drive them home. In the upper Midwest, when we are caring for stubborn Scandinavian and stubborn people who are on their own and they can do it themselves, we've heard it, they may have neglected to arrange a ride home. We have just given them stuff to make them medically sleepy. We have put them in a medically induced coma. Should they be driving themselves home after a procedure where we put them in a brief medically induced coma? The answer is no. So we need to make sure that they have a ride home and that anything that we've told them is also in written instructions. So I'm going to pause here so that I can get into, give you a little bit of a break. And then I'm going to continue on with the next chapter of postoperative care.